Hello, my name is Dr. Amalia Geller. I'm an adult and pediatric neurologist with subspecialty training certification in sleep medicine. I'll be discussing today the sleep disturbances that we see in traumatic brain injury and comparing that to differences that occur between adults and children. My pediatric training in general pediatrics was at the Arnold Palmer Hospital for Women and Children in Orlando, Florida. Neurology training at the University of California, San Diego. Postgraduate training was in epilepsy neurophysiology at the University of California, Irvine, and sleep medicine postgraduate training at the University of Texas Southwestern in Dallas. So first, let's start with traumatic brain injury by definition. This is an injury that will affect how the brain works. There are many symptoms, but to loosely categorize them, we could start with defining it as certain kinds of impairments. Now, there are physical impairments, which usually can involve headaches, vision or hearing deficits, cognitive impairments, which could involve loss of memory, slow thinking, emotional impairments, which could involve mood depression, swings of depression. And it's very important to understand that it is a specialized task to prove the full extent of brain injury symptoms in adults. But even more so, and even more considerations need to apply for children who are victims of traumatic brain injury, whether accidental or non-accidental. Statistics of traumatic brain injury in children involve understanding that it is the leading cause of disability and death in children and teenagers in the United States. The CDC reports that there are two age groups that are greatly impacted by traumatic brain injury, and that is children 0 to 4 years of age, and then children from 5 to 19 years of age. And every year, it's estimated that at least 62,000 children between this age of 0 to 19 will sustain a brain injury leading to actually a hospitalization. And approximately 564,000 children per year will be treated for brain injuries in a hospital emergency room and then discharged. The CDC estimates that 145,000 children and teenagers are currently living in the United States with lasting cognitive, physical, or behavioral changes that were impacted by the traumatic brain injury. And multiple studies have shown the prevalence of sleep disturbance after traumatic brain injury is anywhere from 30 to 70%. Now, do children fare worse than adults when it comes from actually recovering from a traumatic brain injury? Traumatic brain injury in children and teenagers can be very insidious because, remember, the brain is not fully developed. So previously, researchers believed that plasticity of the brain would promote recovery. But this is not true. Traumatic brain injury can actually be more damaging to the developing child or teenager. And following a traumatic brain injury, previously learned information will remain intact. But now the capacity to build that information is jeopardized. And in younger children who have a very low baseline to start with learned information, and even with personality, learning new information that will occur will further brain development can be halted. A differential diagnosis of sleep disturbances following traumatic brain injury includes the following. This could involve obstructive sleep apnea. This can usually come on as a result of weight gain, upper airway obstruction, as related to like metabolic syndrome, where there's increase in cortisol stress hormones following an injury. Central sleep apnea, which can be brought on by the use of pain medications, and even whiplash injuries have been associated with the development of central sleep apnea. Complex sleep apnea and hypersomnia due to medical condition. Children and teens can develop circadian rhythm sleep disorders, as can adults as well. Insomnia, parasomnias, periodic limb movement disorder, and particularly with periodic limb movement disorder, this could often be related to spinal myoclonus, related to back injury from accidents, post-traumatic stress disorder, pain symptoms, fragmenting the sleep, depression and anxiety, also fragmenting sleep, and generalized fatigue that we often see following an accident. Now, in contrast, adults whose brains are developed before the injury, the impact may appear less dramatic. there is a potential delay in diagnosing children. An adult can articulate and demonstrate symptoms they're experiencing, but a younger child may suffer symptoms of cognition, and this may not be apparent at that child's developmental stage, which then can go on to lead to irreparable damage. And a good example of this is if a child is injured as a preschooler, and it's an acceleration, deceleration injury where there's diffuse axonal injury involved, how this is going to impact the child when they're 10, 12, 13, 14 years of age, when that part of the brain should be normally developing, we may not know. And this is why often in personal injury cases, it's usually recommended not to close a case so quickly because we really don't know how that child will fare by the time they're 4 or 5 years out from the accident. And we'll go into this a little bit later. Now, when we want to define mild traumatic brain injury, this is basically a concussion where there is some alteration of mental status. The American Academy of Neurology gives us 3 grades of concussion. Grade 1 concussion, there is less than 15 minutes of confusion, but there is no loss of consciousness, and they have a normal neurological exam. In a case for a grade 1 concussion, the child or teenager may return to play after 15 minutes. But if they've had a previous concussion, it's recommended they usually abstain from sports for at least a week. Now, in a grade 2 concussion, there is confusion but greater than 15 minutes, but again, no loss of consciousness. Here, it's recommended no sports for 1 week. But if this is the second episode for a grade 2 concussion, then it's recommended no sports for 2 weeks. In a grade 3 concussion, this occurs with loss of consciousness, and it doesn't matter how much time has elapsed, how many minutes. If it's their first episode for a grade 3 concussion, it's recommended no sports for 1 week. That's if the loss of consciousness was just several seconds. But if the loss of consciousness rolls into minutes, then it's recommended no sports for 2 weeks. If there is a history of multiple grade 3 concussions, then really at this point we have to basically say no sports for months or basically indefinitely. Pathophysiology of traumatic brain injury. This can be broken up into the types, and here we have a penetrating injury will breach the calvarium. When it's a closed head injury, the calvarium will remain intact. And closed head injuries can be further divided into focal versus diffuse injuries. If it's a focal injury, this is usually involving a contusion, epidural hematomas, intracranial hemorrhages, and these occur by the mechanisms of counter-coup impacts, basically leading to brain bruising. Diffuse injury, however, is when there's more diffuse axonal injury. This is widespread axonal injury. And remember, usually in these types of injuries, there's no real MRI correlate of the white matter changes. Diffuse axonal injuries will usually be the acceleration, deacceleration impacts. And this involves, as I mentioned earlier, diffuse axonal injury. Now, shearing forces involved here would lead to potentially microhemorrhages, cerebral edema, increase intracranial pressure, and changes in cerebral blood flow, which could render on more impact with hypoxia and anoxia. The types of sleep disturbances we see with closed head injuries depends on the location within the sleep-wake brain regions. Post-traumatic hypersomnia, we would be thinking of the areas that maintain wakefulness. The brainstem, reticular formation, the posterior hypothalamus, the area around the third ventricle. High cervical cord lesions can lead to hypersomnia and sleep apnea. And whiplash injuries, which are often involved with acceleration-deceleration impact, can be actually precipitating breathing disordered sleep. So when we compare children versus to adult brains, remember children, their brains are still developing and strengthening vital connections between cells, which we call myelination. And also remember, a child's head is much larger and heavier in many ways than an adult. So you could imagine the impact of an acceleration-deceleration injury, that head on that little body and the force and the impact, and even from side to side. The process of the myelination is like coating of an electrical wire with rubber plastic material and protect the electrical signal as it travels along that circuit. So in a child, when there's incomplete myelination, this is one of the reasons why children may experience an extended loss of memory after a concussion. They will be awake, running around, but later they will not remember anything from the time immediately after the injury. We term this as post-traumatic amnesia. It is usually brief, but it tends to occur more frequently and last longer in children. Hypocretin levels are found decreased in cerebral spinal fluid, less than 110 picograms per milliliter in narcolepsy. Our normal level should be greater than 200. Moderate to low levels have been actually found in the acute injury phase of traumatic brain injury, and they have been found to normalize usually within 6 months post-traumatic brain injury. Now, in the counter-coup brain injury impact, studies have shown this can be associated with insomnia. The base of the skull, usually in the sphenoid region, is usually involved, and this consequent damage leads to the inferior frontal and temporal lobe regions, which involves the basal forebrain area, which are areas of sleep initiation. In closed head injuries, also the suprachiasmatic nucleus could be involved. This could lead to circadian rhythm disorders with concomitant hypersomnia and insomnia, delayed sleep phase syndrome, or irregular sleep-wake cycle. And in the irregular sleep-wake cycle, remember, they will still get the normal amount of sleep within 24 hours, but it is very irregular. Hypersomnia and traumatic brain injury, with or without sleep attacks, can occur after mild traumatic brain injury, and it's estimated to occur in at least 28% of patients. This is often referred to as secondary narcolepsy, also known as post-traumatic hypersomnia. If the hypersomnia persists after 3 months of traumatic brain injury, with or without cataplexy, and with a mean sleep latency of less than 8 minutes, and 2 or more sleep onset REM periods on the multiple sleep latency test, we give this a diagnosis of narcolepsy due to a medical condition. But if the hypersomnia persists after 3 months of traumatic brain injury, and the mean sleep latency is less than 8 minutes, but there are now less than 2 sleep onset REM periods, the diagnosis becomes hypersomnia due to medical condition, also known as post-traumatic hypersomnia. Remember, the prevalence of sleep-related breathing disorder and head injury can be as high as 23 to 25%. Therefore, we must rule this out prior to making a diagnosis of hypersomnia due to medical disorder, post-traumatic hypersomnia. So if a patient with hypersomnia after a car accident, they come in and they're very sleepy, it's very important to screen them for sleep apnea. And usually one can easily implement, particularly in the adults, the stop bang questionnaire and specific sleep questionnaires for children. The next slide is an axial view of MRI showing what looks like the punctated microhemorrhages we discussed. And you can see these from these dark areas are the areas of the punctated microhemorrhages. Here's another example of scans showing the counter-coup injuries following a right temporal traumatic brain injury with hemorrhagic contusions involving the right frontal temporal and left temporal occipital region. This is the CT scan showing the right temporal epidural hematoma with adjacent contusion and vasogenic edema. And the arrow will point to this. The bright area is the area of the blood. Now, this is a case I would like to share with you of an actual patient I had who was a gentleman in his 40s. He worked as a security and loss um, administrator in a department store, and he was involved in a car accident where he had both a counter coup, acceleration, deceleration injury, and he had a very prolonged period of amnesia of about estimated 3 to 4 hours, but without any visible loss of consciousness by the witnesses at the scene. When we obtained an MRI on him, and this would be a sagittal section of it, we can see that the brain is not normal. This was not caused by the car accident. This was actual congenital brain malformation. And we can see here these holes. This is a poor encephalic cyst filled with cerebrospinal fluid, and we can see the brain deformity here. In this slide, on axial view, we see the gray matter here, I'd like to point out, and then we see gray matter in an unexpected place of the white matter. These are called gray matter heterotopias, and these can be potential epileptogenic seizure focuses if the seizure threshold is lowered. Here's a coronal section, and you can really see the malformation of the brain here. Now, this gentleman, his deficits following the injury involved short-term memory loss. He now had to write down everything at work for at least 3 months going forward after the car accident, and it was very difficult for him. He was afraid he was going to lose his job. But we worked with him, and we had neuropsychological testing, and what we found was very interesting for him was on a test that looked at different forms of memory, showed that he scored very low. His neurocognitive index was very low, and this is on a test called the Central Nervous System's Vital Sign Test. And it correlated with quantitative EEG, which looked at brain waves mapped out to certain areas of the brain, which correlated with certain areas of memory, visual motor functioning. So definitely he was impacted by this injury. But interestingly, he scored above normal for the general population in reaction time. So one might wonder, well, how does that work out with this type of brain malformation? Well, it turned out at a very young age, he very intensely studied martial arts and holds several levels of black belt degrees in both Aikido and I want to say Judo. And we discussed this among the neurologists with the group and felt that this probably helped him a lot through childhood for not having such a significant developmental delay in learning and everything, because he did get through school, he did do a little college, but he was able to progress. And he did have a fairly good turnaround after about 6 months of working with TBI and working with neuropsychologists and neurobiofeedback. But this is an example of where he was born this way. And as an adult, he had already gone through his developmental milestones. So his recovery was very good, especially considering the length of time he had post-traumatic amnesia. If this had happened to him when he was in elementary school, or say even as a preschooler, the likelihood of him having a greater impact from this traumatic brain injury once he became an adolescent or even at 10, 11, 12 years of age could have been quite significant and could have presented itself as both learning difficulties as well as personality difficulties socially. So in closing, sleep disturbances can occur in about 30 to 70% of children and adults with traumatic brain injury. Insomnia, fatigue, and sleepiness are the most frequent complaints that we see after head injury. Adults have more physical symptoms that they can relay, such as headaches, balance problems, and fatigue. However, children, they're more likely to show behavioral symptoms such as irritability, drowsiness, and insomnia. And just because they may not complain of a headache, remember, does not mean that they're okay. So the two main types of traumatic brain injury leading to altered sleep involve your contact and acceleration-deceleration injuries. Disorders of sleep after traumatic brain injury can be diagnosed through tools such as polysomnogram, multiple sleep latency tests, and/or actigraphy, which is a test measuring movement. And remember, treatment is specific. So this could include the use of medications, continuous positive airway pressure, BiPAP, adaptive servo ventilation, cognitive behavioral therapy, and behavioral modifications. Thank you very much for allowing me to share this information with you. If you would like to reach out to me with any questions, I've provided for you a phone number contact as well as my email. Thank you very much.